Hello, my name is Saad Usmani. I'm the Chief of the Myeloma Service at Memorial Sloan Kettering Cancer Center. And on behalf of the RedirecTT-1 study team, I'm going to be sharing with you the efficacy and safety data of the combination of Talquetamab and Teclistamab in relapsed refractory multiple myeloma patients with extramedullary disease. These are the updated results of the Phase 2 study. Just to highlight something very important, extramedullary disease is associated with poor survival in multiple myeloma, and it's a more aggressive biologic entity. We must differentiate it from what we call paramedullary disease, which is bone-dependent plasmacytomas that grow outside of a disrupted bone cortex, whereas true extramedullary disease is when there is hematogenous spread because the myeloma cells are emancipated from the bone marrow microenvironment and can go to different soft tissues or organs and grow there. And these patients have poor outcomes, as you can see on the right side, with standard of care treatment in terms of overall responses, progression-free, as well as overall survival. Patients who have true extramedullary disease don't do that well with standard of care treatments that are available to us. So with this in mind, I want to share the schema of this study. We treated roughly 90 patients with the combination of Teclistamab and Talquetamab. Initially, step-up dosing was given for both of these therapies. So 3 step-up doses were given before full doses of Talquetamab, 0.8 milligram per kilogram, and Teclistamab, 3 milligram per kilogram, were given every other week subcutaneously. And the primary endpoint of this clinical trial was overall response rate. Prior CAR T cell therapy and non-BCMA bispecific therapies were permitted. And here the true EMD was radiographically defined as more than one or more non-radiated bone-independent soft tissue plasmacytomas that are 2 or more centimeters in greatest dimension. And this was centrally reviewed by PET scan. Now, another very important feature of this trial was the fact that we incorporated, in addition to the International Myeloma Working Group response criteria, the gold standard dual and impetus criteria for imaging. So, for example, CR meant that disappearance of all plasmacytomas or persistence of fibrotic disease with a PET score of 1 to 3. And VGPR and PR were more than 90, equal to or more than 90%, or equal to or more than 50% reduction in size in all plasmacytomas with reduction in PET avidity. In non-secretory disease, response was evaluated by functional imaging, and IMWG criteria also had to be met for complete response. So this is the salient characteristics of the patient population. Median of 4 prior lines of treatment, median age of 64 and a half years. What I do want to point out is we did have non-secretory and oligosecretory patients on this clinical trial, and a major proportion of patients who were triple class refractory and refractory to the last line of treatment. So this is the overall response rate at a median follow-up of almost 17 months, very impressive at 79%, with a CR or better rate of 53%. And the durability of response at the 12-month mark was 62.1%. This is quite impressive for this patient population, especially in the context of the historic data that I showed you on the second slide of this presentation. One point I want to highlight is the PET response and how we evaluated the PET response in patients. So you can see that patients, this particular patient had gastric EMD and a very high M spike value. But while they were having a response biochemically, we had to look at the 5-point dual scale and really call it a complete response after it gets into the appropriate scale of between 1 to 3. So, that's how this response criteria was evaluated and incorporated in the clinical trial. Now, looking at where the EMD happened, whether it was in an organ or soft tissue, the responses were very similar, whether it was in organ or lymph node or soft tissues. So dual antigen targeting did achieve deep response regardless of the location of EMD. Another very important feature was the volume or the burden of disease with EMD, and this is where I think this becomes very important. So, looking at less than 25 centimeters square of baseline EMD tumor volume, those are the patients that had the best overall response at 93% and CR better at 58%, whereas patients who had 25 to 50 or more than 50 centimeters square of baseline EMD had similar responses at 67 and 65%. Looking at the PFS at 12 months for the overall population with this additional follow-up was 57.5%. And remarkably, the overall survival was roughly 74% at the 12-month mark. So median OS has not been reached. Median PFS was about 15 months for this patient population. Looking at the AE profile, infections, grade 3 or higher, were there in about a third of the patients. And once you move to Q4 dosing, they become about 25%. And then intravenous immunoglobulin or IGRT was utilized for this patient population. In addition to this, the Talquetamab side effects were similar to what has been described in the relapse population with the monotherapy. Looking at the pattern of infections, primarily upper respiratory and lower respiratory tract infections, including COVID-19 infections were noted, generally consistent with what has been reported and observed in the Majestic-1 study. Almost three-fourths of the patients received IGRT replacement, during this time. Looking at discontinuations, 8 patients discontinued treatment due to AEs, and there were grade 5 events. You can see non-infectious were primarily aspiration, respiratory. There was one patient, who decided to go towards hospice and euthanasia, and then the infections you can see include pseudomonal Escherichia or E. coli sepsis, Klebsiella pneumonia, COVID pneumonia, and Klebsiella sepsis were noted. So, in summary, this combination looked at deep and durable responses for true EMD with the combination of TAL and TEC, and with subsequent follow-up, the deep overall response of almost 80% with CR better of 53%. The median PFS 15 months, median OS has not been reached. The overall response rate was high regardless of the EMD location, and low EMD burden was associated with higher overall response rate. So the dual targeting GPRC BCMA strategy with TEC-TAL is going to be a very important armament addition to how we approach treatment for true EMD patients who are triple class exposed with relapsed refractory disease. And with this, I want to share that the paper did get published in the New England Journal of Medicine and is available for readership. Thank you so much.